hand it over to our presenter, Dr. Tawil from the University of Rochester Medical Center.
Thank you. So these are the objectives of the program. We'll try to understand the genetic etiology of FSHD, identify clinical manifestations, understand the role of multidisciplinary care, gain awareness of ongoing clinical trials, and refer patients to participating opportunities, and also locate additional tools and resources. So we'll have an overview, some description of the genetic etiology, clinical features, diagnosis management, clinical trials and emerging therapies, as well as resources. So FSHD is one of the most common adult onset muscular dystrophies and affects the muscles of the face, shoulders, and upper arms. We'll come back to that. The FSHD name is not really true to what it really is. It's much more severe than people think because it's not limited to those muscles, and we'll talk about that. So it's a slowly progressive disease with variable symptoms, gradual muscle weakness that typically starts in the face, shoulders, and upper arms. But again, and very asymmetric weakness. But again, that particular a progression of weakness in those particular muscles is not that common if you look at all of the patients with FSHD. Again, it's one of the most common adult onset muscular dystrophies with a prevalence of 1 in 8,000 to 1 in 20,000, depending on what studies that were done. But I think it is consensus is more like that it is closer to 1 in 8,000 in a study that was done in the Netherlands. The onset, it can occur at any time from infancy to middle age. Most people begin experiencing symptoms by the age of 20. People who develop symptoms at an early age often experience more severe disease, sometimes leading to wheelchair dependence. It is typically not life-threatening, but it does have, and it does not significantly affect lifespan. But there are certain exceptions, especially in patients who develop restrictive lung disease from the FSHD. So we're going to talk about the role of DUX4 in FSHD. So in FSHD, inappropriate expression of the DUX4 gene on chromosome 4q35 in skeletal muscles activates genetic programs that lead to downstream functional consequences. DUX4 is a transcription factor that plays a role in embryonic development. It's normally expressed in testes and thymus, but not in somatic cells. On chromosome 4q35, there are multiple tandem copies of DUX4 contained in 3.3 kilobase macrosatellite repeats called the D4Z4 units. And usually you have between 11 to 150 repeats. This type of structure in the chromosome is usually where you see genes that are not expressed because they're tightly bound and hypermethylated. So there are genes that are not usually expressed. So inappropriate DUX4 expression is caused by two things. You can shorten the D4Z4 region to 1 to 10 repeats. Again, the normal is between 11 and 150. And you have to have the D4Z4 repeat. In that contracted repeat, you should have a 4QA variant in the most distal D4Z4 repeat because that allows the production of a steady RNA. The inheritance pattern, 95% is autosomal dominant, and in FSH2, it's digenic inheritance, and we'll come back to that. The downstream effect of the expression of DUX4 is it can cause inflammation in the muscle, can cause muscle atrophy, increase susceptibility to oxidative stress, and can disrupt myogenesis as well. Okay, I'm going to go through a couple of slides to show you in images exactly what we're looking at. And so you see the chromosome 4q35, and we are at the tip of 4q35. And on the left side, if you have a 4qa variant, which is the last, which is just adjacent to the last D4Z4 repeat, and you can cause FSHD by two ways. One, you can basically unravel the D4Z4 repeats by contracting the number of repeats. And if you have a 4qa variant at the tip of that sequence, then you can have a steady mRNA with the polyethylation repeat at the right side end of it, and that can produce toxic DUX4 protein. On the other hand, if you have a 4qb variant, even if you knock the number of repeats down to 1 to 10 repeats, you're not going to have a stable mRNA, and so you don't produce DUX4 protein. In type 2, it's a little bit different. The type 2 happens because of a mutation in the SMCHD1 gene, which is the one that causes 95% of FSHD type 2. The SMCHD1 gene's role is it regulates methylation of different parts of your genome and opens up the methylation if there's a reason to express that particular gene, or keep them tight and not expressing the particular gene. So on the left side here, if you have a defective SMCHD1 gene, it's not going to be able to keep that sequence tightly bound. And again, if you have a polyethylation sequence at the very end of the last repeat, then you can produce DUX4 protein, which is toxic to muscle. Again, similar to type 1, even if you have a defective SMCHD1, but if you don't have a polyethylation sequence at the very tip, then you're not going to be able to produce DUX4 protein. And again, beside the SMCHD1, which accounts for 95% of SMCHD of FSHD2 patients, there are two other genes that are much less likely to cause. There are very few reports of those two genes, but there are definitely genes that can cause FSHD as well. So again, this is a summary. Again, on the one side, on the left side, the FSHD results from contraction of the number of repeats, which unravels the whole setting of the chromosome. Or you have an SMCHD1 mutation that causes FSHD type 2. Both of them cause toxic DUX4 protein, and subsequently the clinical manifestations of both are essentially identical. So in FSHD type 1, we know that the disease severity is variable, and it depends on the number of residual D4Z4 repeat size. And we know that if you have 1 to 3 repeats, these are typically the more severely affected individuals and often early onset disease. 4 to 7 repeats is where most individuals with FSHD2 are. It's relatively moderate in disease severity, and that's where most of the patients with FSHD are in that category. If you have 8 to 10 repeats, you usually have later onset disease, you have milder disease, and sometimes it is asymptomatic. And if you look at the age at first wheelchair use, and this is from the University of Rochester registry, the data is showing what this graphic is showing you that if you have a large repeat, if you have 1 to 3 repeats, you have a large number of patients who have who become wheelchair bound. This is less so in the medium size of 4 to 7, and least in those who have 8 to 10 repeats. So FSHD suggests a limited, fixed, typical pattern of rostrocaudal muscle involvement, but there's as many exceptions to that rule as there are typical patients. And you have to keep that in mind because, again, I think there's it also reflects a little bit of what happens in pathology of FSHD. So the primary abnormalities is that, again, you have a distinctive pattern of weakness, face, shoulders typically, with characteristic shoulder involvement. Again, the muscle group that becomes involved earlier does not necessarily become very affected by the time, for example, a lower extremity muscle is affected. And this, I think, is a reflection that the progression in FSHD can be halting, and a lot of patients can be very steady for a number of years. So there's rapid progression in muscle groups, as I mentioned. It can be in the same individual. There's wide-ranging severity from minimal symptoms to wheelchair-bound, as we mentioned, 20% above the age of 50. You can get restrictive lung disease, depending on the studies that you look at. That ranges from between 10 to 20% of individuals with FSHD. There are non-skeletal muscle involvement in FSHD that is usually restricted to early childhood onset disease, and that includes hearing loss, Coats disease that is causes retinal hemorrhage and can result in blindness, and in a small minority of patients who have childhood onset disease, you can get some cognitive impairment. All three of these characteristics that I'm telling you about are even in the patients who have very few repeats. These are fairly rare overall, but are important to look after because, again, not picking up hearing loss at an early age can delay the progression of a young child. I think Coats disease is self-evident. It can be very severe. Some individuals, if not treated early on. Again, so now we're going to look at some of the clinical features. This is a lady with FSHD, and on the left side, I'm asking her to smile, and you can see the asymmetry of the smile. And on the left side, I'm asking her to whistle, and you can see that she can do that better on one side than the other. This asymmetry of muscle involvement is very characteristic of FSHD, and you don't really see that in most of the other muscular dystrophies. So that should always be a warning sign that you're looking at somebody with FSHD when you see that type of an asymmetry. Again, some of the other clinical features of typical patients with FSHD, you have kind of the chest muscles are often involved early on, and you can see the axillary fold, which is manifested on the left side. And you can see that because the upper parts of the chest muscles are atrophied. The clavicles are straight rather than being at an angle. And again, if you look from the back, you can see this patient again showing the asymmetry and the involvement of the scapular muscles. The other important feature, and causes a lot of difficulty for many patients, even if they're not wheelchair bound, but it can affect their ability to walk. Core muscles are affected, paraspinal muscles and abdominal muscles. And on the left side, you can see somebody who's fairly lightweight, but he has a prominent abdomen just because the abdominal muscles are weak. On the right side, this is somebody with very severe paraspinal muscles. And if he is to try to straighten himself up, he will fall forward, and this is the only way he can manage to walk independently. And again, focusing a little bit on the asymmetry of involvement, which is kind of always find peculiar to me. On the right side, upper right-hand side, are identical twins. And you can see one is on the right, one is on the left. Those biceps don't work on one side and are completely normal on the opposite side. On the right side, you can see the person with, again, scapular winging on one side, but on the other side, completely normal. And again, abdominal muscles are weak in the lower, the part of the abdominal muscles below your belly button are weaker than the upper ones. And so if you have somebody lie down and lift their head and activate their abdominal muscles, you get what we call the beaver sign, which is the movement of the belly button upwards. Next. And this is kind of an important thing to do, I think, for most of the patients, and to see if their scapular winging is potentially fixable. And so I'm standing behind that patient and pushing on his scapula into his chest wall and holding from the front. And you can see that he gains almost full range of motion by doing that. This is somebody who may benefit from surgical scapular fixation. I'm not going to talk very much about scapular fixation, but it's not something to take it's a significant procedure and can have a lot of side effects, but it does, if you choose the right person, it may be very important in the life of that individual. Next. FSHD diagnosis, genetic confirmation is unfortunately a little bit difficult because it's expensive, because you have to measure multiple things. You're not looking at a point mutation of a gene. You're looking, so it is complicated to do. And so for FSHD type 1, you have to look and see if you have 10 to 40 repeats in your DNA on chromosome 4. Or if you have a contraction of that to between 1 to 10, then you have FSHD type 1. Again, provided that you can show that the last D4Z4 repeat has an A variant attached to it that allows the production of the DUX4 gene, DUX4 protein. In FSHD type 2, it gets a little bit more complicated. Again, you have to show that you have equivalent repeats between 10 and 20. Again, that's in the normal range, but if you demethylate that region and you have an A variant, that's enough to cause the production of DUX4 again. So you have to, again, measure the size of the repeat, determine that you have an A variant, permissive A variant, and then measure the hypomethylation level. And it can be confirmed by looking at SMCHD1, which is the most common and only sponsored gene for testing for FSHD type 2. Next. So FSHD management, there are currently no established treatments for FSHD, but neuromuscular disease clinics can help patients at multiple levels. Again, a lot of patients with FSHD, because of asymmetry of involvement, oftentimes will have lower back pain, upper back pain, especially if they have asymmetry in their scapular winging. So pain management is often very important. Physical therapists are very good at managing progressive weakness and advising on exercise programs and the use of assistive devices. Periodic monitoring of lung function is more severely affected individuals, especially patients who become wheelchair bound or have a higher tendency of getting restrictive lung disease. So this should always be on the list of to do periodically for patients who are becoming weaker. And again, evaluation by an experienced surgeon if you're considering scapular fixation in the patient. And there are really a handful of surgeons across the country that do this surgery and do it well. And again, access to a genetic counselor is very important in patients. Patients who are, individuals who are planning to get married or are married and are planning to have kids. Next. Severe early onset FSHD may require additional therapy for muscle weakness and additional monitoring of breathing and hearing function. Again, as I mentioned, these are important. And again, I should add to that is the retinal involvement and monitoring that as well. So monitoring treatment of severe muscle weakness, and again, physical therapists are very good at trying to help patients deal with increasing weakness. And physical therapy is very important for contractures. Let me backtrack a little bit on that. The contractures are actually very atypical in FSHD, and most people don't have contractions. They might have a little bit, but much less than what most other FSHD, most other muscular dystrophies patients have. And this is often can be a clue that you're dealing with somebody with FSH. And again, exercise is important for FSHD and has been proven in more than a couple of studies that they benefit patients and make them stronger. Again, specialist care, monitoring pulmonary function, monitoring treatment, as we mentioned, hearing loss, and trying to pick that up early on. That's very important for kids who are who may not get. I guess it's being done more now in very early onset in very young kids. So, but if it's missed, it can be devastating for patients. Retinal vascular disease again just requires periodic evaluation by an ophthalmologist. Next. So potential therapeutic targets. Basically, again, you have two causes for FSHD, FSHD1 and FSHD2. So there are potentially different approaches to it. You can potentially increase SMCHD1 and try to basically close up the area, the distal area of the repeats, and enhance epigenetic repression. This is still kind of more hand-waving than anything. I don't think anybody has come up with a way of doing that at this point. Most of the emphasis is on antisense oligonucleotide and AAV-mediated RNAi. Lastly, but probably the least effective would be reduction of DUX4 protein, and maybe trying to deal with target DUX4 effects downstream from the production of DUX4 protein itself. Next. So there are emerging targets in FSHD that have set the stage for drug development and evaluation of clinical trials. Some of you may know about these active trials. The first study was done by Fulcrum. They used the drug losmapimod, which is a repurposed drug. It's a MAP kinase inhibitor. It was shown repeatedly that it can block DUX4 activity in vitro. So losmapimod, Fulcrum is now in phase 3 trials. The first two phase trials, phase 1 and 2 trials, showed some benefit in patients who were on active disease as opposed to placebo. So this study is ongoing. Avidity Biosciences is coming with siRNA, silencing DUX4. The study is called Fortitude, and it's in a phase 1/2 phase right now, with 5 doses given IV intravenously over 9 months with 3-month follow-up. Part A, B, and C test different doses of the regimen, and eventually, if this proves to be effective, then they're going to move on to a phase 3 study. There is some already some in other studies that Avidity has used similar interventions, seems to have worked in some of the other neuromuscular diseases. Lastly is Roche, and it's using a humanized monoclonal antibody that inhibits myostatin. The study is called Maneuver. It's in phase 2 trial. So myostatin inhibitors have been used in the past. There's been 2 studies with myostatin inhibitors, one in a multitude of neuromuscular myopathies back in when was it, in 2007 or so. That did not seem to work. Subsequently, more recently, Acceleron did a direct injection of myostatin inhibitor in a study of patients with FSHD. Also, did not show benefit for patients with FSHD. Roche has a new drug that is apparently very potent in the experiments that they've done so far. And again, this is not a targeted treatment, but it can be a supplemental treatment on top of a targeted treatment if it proves to be effective. And Maneuver is starting in the next couple of months. So the FSHD clinical trial network, FSHD-CTRN, is a consortium of 23 academic research centers in the US, Canada, and Europe with expertise in conducting FSHD in clinical trials. And we started that in about 8 years ago now, with funding from NIH, with the idea that we needed to learn more about the progression of FSH in order to be ready for clinical trials, and also look for potential biomarkers for clinical trials. So there are multiple ongoing trials right now, mostly observational studies, basically to enhance our understanding of what happens over time with FSHD. So there's a move, FSHD, which is recruiting at the present time. There's an FSHD registry, which has over 1,000 patients with FSHD in that registry, and they're trying to recruit more patients. This is more of, again, this is can be reached by companies for recruitment, but we've also learned a lot from the 20 years of data that we've collected from these patients. So again, key references. There's the NMC management guidelines, even though they're from 2010, they really still are kind of up to date. The second additional reference that's worth looking at is FSHD muscular dystrophy, the road to targeted therapies. Sponsored genetic programs do help pay for patients who need to have SMCHD1 testing. It does not include testing for FSHD1 at this point. The major lab for testing is at the University of Iowa for testing for FSHD in general. And again, clinical trial resources. We talked a little bit about the registry, and if anybody wants to know more about what's going on in clinical trials, the NDA clinical trials updates and Finder, clinicaltrial.gov, as most of you know. Also, the FSH Society on its website will keep an updated area for what's going on in clinical trials. Thank you.